Brilliant. So a very good morning to everyone and welcome to today's meeting. So this is day one in a series of 2 events that we're running to help ensure trials answer the question of interest. And this is the implementation of the Estimand framework. Now, right now, an Estimand might not mean anything or be overly familiar to you, and that's fine. It means you're actually in the right virtual room, as that's exactly what we're going to talk about today. So I hope by the end of today, you have a good understanding of exactly what an Estimand is and why we should be using them in our trials. Okay, so just to start today, I'm going to cover a bit of standard online housekeeping, followed by an introduction to today's event. So this will include the aims and objectives, followed by an overview of the sessions and upcoming individual talks. So I'm delighted that I've got some fantastic invited speakers joining me here today, both clinical and statistical. Now on housekeeping, as we have just over 340 people registered for today, I hope you'll understand that for non-speakers, we've got microphones and videos off. Otherwise, it could descend into Zoom chaos. Now, we do have some times for questions following talks. So if you have any burning questions for speakers, we'd like to ask if you can put these in the Q&A window, which you should find at the bottom or top of your screen, this in the Zoom panel. And we'll answer as many as we can get through. And we have got limited time for questions, but we'll try and see as many as we can do. You'll notice there's also a chat window, but we will only be taking questions from the Q&A panel. Now, we will also be making recordings of today's talk available afterwards, and we'll provide you with the links to these via email when these are ready. And we expect this will probably be in about a week or so. If you do have any general queries about today's event, please contact Ruthie Parsons, who's helping me run today's event. So you can contact her directly with a private message in the Zoom chat or via email as shown on screen. So a very warm welcome to today's event. So we're delighted to have so many of you intrigued to hear about Estimands today. So this event is kindly supported by the MRC NIHR Trials Methodology Research Partnership. So this brings together a number of networks, institutions and partners working in trials and trials methodology research. Now, for more information on the network, you can check out their web link on the screen. But the partnership has 8 working groups, and they recently provided funding to support projects led by TMRP working group members. So this included a project led by myself from the Statistical Analysis Working Group. And this project included a workshop for trialists to show why and how the Estimand framework should be used, which is what brings us all here today. So for those of you who don't know me, I'm an Advanced Research Fellow and Head of Trial Methodology at Imperial Clinical Trials Unit. So Dr. Brennan Kahan from the MRC CTU at UCL has provided co-leadership on this with me. And other investigators working with us include, also from Imperial, Dr. Victoria Cornelius, from the MRC CTU at UCL, Professor Ian White and Professor James Carpenter, and from King's College London, Professor Richard Emsley, and from the University of Aberdeen, Dr. Beatrice Gulo. So this event follows the publication of the ICH E9R1 addendum, which introduced the Estimand framework and set out guidance to follow to design trials that address clear and useful questions. So today we aim to give you an overview of the addendum and what it's all about, including what an Estimand is and what the Estimand framework entails, so that you can understand why and how we should be using the framework and all the benefits that it brings. And this so that we can increase the use of Estimands in our trials. Now, specifically, we hope by the end of the meeting that you'll be able to understand what an Estimand is, understand what intercurrent events are, and understand the principles of the ICH E9R1 addendum and the Estimand framework, and also to understand why implementation of the Estimand framework is important. Now, to achieve these objectives, today's meeting is going to proceed as follows. So I'm going to continue chairing this first session, which is on an introduction to Estimands. During this, you'll hear from some excellent statistical and clinical speakers. The key aspect we'd like you to take away from today is that Estimands are not just for statisticians, they're for everyone involved in running trials and also for everyone using trial results. Now, our first speaker is going to be Dr. Brennan Kahan. So he's going to give us a nice introduction to Estimands. And then we're going to have a talk on the use of Estimands in diabetes trials by Dr. Thinzar Mim. And then this will be followed by an in-conversation session with Professor Amanda Adler. And then around 10:45, we're going to stop for a short 10-minute comfort break. And then after the break, session 2 will commence on the Estimand framework and implementation in practice. So this will be chaired by Dr. Victoria Cornelius, who's Head of Statistics at Imperial Clinical Trials Unit. And this session will start with a more detailed overview of the ICH E9 addendum and the Estimand framework. So I'll be giving that talk. And then there'll be a shorter presentation on the use of Estimands in the published literature that I'll also be giving. And then we're going to look at our current practice together using a few Zoom calls, because also really keen to hear from you today. And then really looking forward to our last talk of the day from Chrissy Fletcher, who's a member of the ICH E9 working group. So she'll be giving us a talk on ICH E9 R1 implementation experiences. And that will lead us to the close of the day's meeting, which should be around 12:30. Now, tomorrow we do have a follow-on workshop going further into how to implement the framework with some additional case studies and practicals. And I'm afraid we did have to limit places for this, so apologies to anyone joining today who did also want to join that but didn't get a space. But I wanted to let you all know that we will be making recordings from day 2 available, so you'll be able to review all the material from day 2 in your own time. Okay, so you've heard all about today and who you'll be hearing from. So now what about you? I think just so that we know who we're all in the virtual room with, I'd like to just launch a couple of Zoom polls so we can get a feel for this. So I'm just going to launch and ask you to fill in 2 questions here. So the first question we'd like to ask is, what's your experience of working in trials? And so you've got a few options. It might be that you're completely new to trials and you're just interested to hear today, or you might have 10 years plus experience. So if you could just fill in your answer to that. And the second question we'd like to ask is, how would you describe your role? So how would you primarily describe your role? So are you a statistician, a clinician, a clinical researcher, or maybe you work in trials operations as a manager or something else? So I can see we've got lots of responses come in. I might just give you 20 more seconds just to have a fill these in. This is just really nice and helpful for all of us here to see who else is here with us today. Brilliant. So I might just give you 10 more seconds. Looks like we've got responses have stopped coming in, so I'll just end the poll now and share the results with you. So it's brilliant to see here. Actually, we've got a variety of experiences. We've got some people who are new to trials, so welcome to you today. But we've also got people with much more experience. And then looking at the roles, you can see we have got a predominantly statistical audience here, but I'm really pleased to see that we've also got some clinicians and clinical researchers, and also some trial operations joining us, and some others. So that's brilliant. So I'll stop sharing the Zoom poll with you now. So I hope that you do all enjoy today's meeting, and by the end you do see that Estimands are for everyone and how they can help us to improve our trials. And the last thing I just wanted to mention here is that if you are a Twitter user and want to join in with increasing the profile of Estimands today, do feel free to tweet and use the hashtag Estimands, so we can increase talk and hopefully interest around Estimands in our trials and what they are. Brilliant. So without further ado, I'm going to stop sharing my screen. And I'd like to introduce today's first speaker, is Dr. Brennan Kaham. So Brennan is a Senior Research Fellow in Trials Methodology at the MRC Clinical Trials Unit. He has expertise in Estimands, complex trial design and efficient statistical estimation. And he also has a wealth of applied trial experience. So he's going to start today with an introduction to Estimands, including why we should care about them. And just want to say, if you've got any questions for Brennan, do put these in the Q&A panel and we'll ask him at the end. But for now, over to you, Brennan.
Thank you, Susie. Well, I'm really excited to be here to kick off today's session on Estimands. So I've been working in clinical trials for a little over 10 years now. And I think for me, Estimands are really the one concept that have most changed the way that I think about how we design and analyze trials. So today's session is really going to be a quick introduction to what an Estimand is and why I think they're so important. But before I get into that, I'm just going to give an example, I think, of one of the problems that we see in practice that I think Estimands were really designed to resolve. So I'm going to do that using an example. So, so this is a trial I came across a little while ago. This was looking at the use of cabazitaxel in patients with metastatic prostate cancer. And the main outcome measures were overall survival and progression-free survival. But they also looked at quality of life as a more exploratory outcome. And I think this is really important because I think often with cancer treatments, we might worry that because of increased toxicity, they might actually reduce quality of life. So it was really nice that they evaluated this, and they actually showed that not only did cabazitaxel not reduce quality of life, it actually led to a pretty substantial improvement in quality of life. Now, when I read this in the manuscript, my initial interpretation of this was this meant that if we were to give all participants or start them all off on cabazitaxel, it would improve their quality of life on average by 0.08. And I think most people reading the manuscript would probably come to the same conclusion. But this actually isn't right. So this is not what that treatment effect represents. So this 0.08, this is actually an estimate of what the treatment effect would be in the hypothetical setting where men with metastatic prostate cancer never experienced disease progression and never died. So let's just think about that for a second. So cabazitaxel is given specifically to prevent occurrence of disease progression and death. So what this treatment effect is saying is that in the setting where we don't have to worry about these things, so in the setting where we don't need to give cabazitaxel, in that case, it's actually quite effective at increasing quality of life. Now, I don't want to say that this type of treatment effect isn't clinically relevant. I think there might be very good reasons why this is useful, but I do think that if we're going to be using these trial results to make decisions on whether to use cabazitaxel, we need to understand what this treatment effect means. Because if we don't, then I think it's going to be really hard for us to make an informed decision. And the issue is that we are never given a definition of what this treatment effect actually means in the manuscript. And this isn't an issue particular to this trial. So this is actually, I think, an issue that kind of affects most trials that we see, where we're not told what the treatment effect represents. We're only given the study methods. And if we want to understand what is being estimated, what that treatment effect represents, it often feels like we actually have to play detective and do some detective work to kind of scroll through the study methods, collecting clues to see how they work together and what they're actually estimating. And in practice, this can actually be really, really difficult. So in this cabazitaxel example, this kind of interpretation of the treatment effect is down to a slight quirk of the study methods, I think, where the investigators stopped collecting quality of life data after patients experienced disease progression. So quality of life scores were set to missing after disease progression or after patients had died. And then they used a mixed effects model to do the analysis. And what this model did is it implicitly imputed what those missing quality of life scores would have been had patients not experienced disease progression and not died. Now, to understand what this treatment effect means, we actually have to have a pretty in-depth understanding of the mechanics behind how mixed effects models work. And I think in practice, most of us aren't necessarily going to have this level of detailed understanding of how all the different advanced statistical methods that we use in practice, how they work. And I think right there, that's the issue, that often we just aren't going to have the ability to understand what the treatment effects we see in published papers, what they mean, and we're never told what they mean. And that is what an Estimand does. It is tells us in kind of clear language what the treatment effect is and what it represents. So here it tells us explicitly that this is the treatment effect in the hypothetical setting where men with metastatic prostate cancer don't experience disease progression or death. So we don't have to do that kind of background detective work to try to figure out what a particular statistical model is doing in a particular situation. The Estimand just kind of comes out and tells us plainly what we're looking at. So Estimands, I think, are really about removing ambiguity about what treatment effects mean. So they provide us a structured way of defining the treatment effect to make it clear to everyone what it is that's being estimated in our trial. And it's really only once we get that clarity around what we're estimating that we can make sure that what's being estimated is actually clinically relevant, so that we're actually answering the question we set out to answer in our trial. And it's only with that clarity that we're able to then align the study design, so the design of the trial, the data that we collect, and the statistical analysis to that Estimand to make sure that we're actually able to estimate the right thing in our trial. So like Susie said, I think attention around Estimands has really been kicked off with the publication of the ICH E9 addendum towards the end of 2019. Now, the addendum defines an Estimand as a precise description of the treatment effect to be estimated, and it's comprised of 5 different aspects. So the first aspect, this is the population of patients we want to estimate the treatment effect in. Now, this might not always be the same as our trial population. So it might be that we're interested in estimating the treatment effect in the subset of patients who would adhere to treatment if allocated to it. So here, the population in the Estimand is actually a little bit different to the trial population. The next aspect are the treatment conditions we want to compare. And again, these might not be exactly the same as the treatments kind of described in the protocol. So for instance, in the protocol, we might allow patients to switch from one treatment to another under certain circumstances, but in our Estimand, we might actually want to evaluate the effect of a version of treatment where patients were not allowed to switch. So the next aspect is the endpoint or outcome that we measure on each patient. Then we have the summary measure, so a summary of how we compare endpoints between the different treatment conditions. And the final aspect we have are how we handle intercurrent events in the definition of the treatment effect. And I think intercurrent events are often the most challenging aspect of the Estimand. So I'm just going to spend a few minutes talking about what intercurrent events are and the different ways that we can think about handling them. So an intercurrent event, this is a post-randomization event which affects either the interpretation or the occurrence of outcome data. And most often, I think these are things which kind of affect patients receiving the intervention. So when the patients stop taking a treatment, when they never start taking treatment in the first place, when they switch from one treatment to another, if they get the wrong dose of treatment, or they use rescue medication or other non-trial treatments. And I think each of these things can affect kind of our interpretation of what outcome data mean. So for example, if we have 2 participants, the first one receives their full dose of treatment, and the second one takes 1 dose of treatment and then stops, I think we'd probably feel a little bit differently about what the outcomes from these 2 patients tells us about how useful the treatment is. So there are a number of different strategies or methods that we can use to handle intercurrent events in our definition of the Estimand, and different approaches are going to lead to quite different types of treatment effects. So it's important that we kind of think carefully about what we want to do here. And I'm just going to go through and explain what each of these different strategies mean. And I'm going to do that using an example. So if we imagine we have a trial looking at a daily drug tablet against a matching placebo with the aim of preventing disease recurrence within 12 weeks. So that's our endpoint. And the intercurrent event is that some people are going to stop taking their tablet early. So we have some people who discontinue the treatment. So the first strategy I'm going to talk about is what's called a treatment policy strategy. And I think this is probably the most commonly used strategy. And this is where the intercurrent event is considered to be part of the treatment condition itself. So what we do is we use the patient's recorded outcome in the calculation of the Estimand, regardless of the fact that the intercurrent event occurred. So it's considered part of the treatment strategy. So we're interested in the effect of the intervention, regardless of the fact that some patients discontinued treatment. So the next strategy is the hypothetical strategy. And this is where we consider a hypothetical setting where the intercurrent event would not occur. So we're interested in the effect of the intervention in a hypothetical setting where participants would not discontinue treatment. So where everyone continued taking the treatment to its full course. The principal stratum strategy. So this is where we're interested in the treatment effect in the subset or the principal stratum of patients for whom the intercurrent event would not occur. So we're interested in the effect of the intervention in the set of patients who would not discontinue treatment. The next strategy is a composite strategy. So this is where the intercurrent event is just incorporated into the endpoint definition as a composite endpoint. So we change the definition from disease recurrence to disease recurrence or treatment discontinuation. And here we're interested in the effect of the intervention on the composite of recurrence or treatment discontinuation. And the final strategy is what's called a while on treatment or a while alive strategy, depending on which intercurrent event we're applying it to. Here, we're interested in the endpoint prior to the occurrence of the intercurrent event. So we use kind of the endpoint measured up until the point that the intercurrent event occurs. So here, we're interested in the effect of the intervention on disease recurrence up to 12 weeks or up until the point of discontinuation, whichever happens first. So I think most trials are going to see a number of different types of intercurrent events, and we don't need to choose one strategy for all different types of intercurrent events. We can use different strategies for different types of intercurrent events, so we can mix and match depending on our objectives. And we can also subdivide intercurrent events by reasons. So for instance, we might want to define treatment discontinuation because of adverse events, as well as treatment discontinuation for other reasons. And it might be that we want to handle these types of intercurrent events differently in our Estimand. Now, I'm just going to finish up with an example to kind of highlight the importance of thinking through both the Estimand and the study methods and what can happen when we don't. So a lot of trials in advanced cancer will test a new experimental treatment against a standard control treatment. Usually the aim is to see whether the new treatment will extend overall survival. Now, in practice, when patients experience disease progression, they are usually switched off of their current treatment, whether that's the experimental or the control, and they're switched on to a kind of second line standard of care treatment. So if our aim in practice is to evaluate the effect of the experimental treatment as a first-line treatment if it were added to usual care, so if we're thinking of doing a pragmatic trial, for instance, then what we actually want to compare here is the experimental treatment plus second-line standard of care against the control also with second-line standard of care. Now, some trials in practice will actually use a slightly different design where they will let people on the control arm who experience disease progression switch to the experimental treatment, even though the experimental treatment would not be available as a second-line treatment in practice. So this design is really comparing the experimental treatment plus standard of care against control with a second-line treatment being the experimental. So in this example, treatment switching is acting as a really important intercurrent event And we need to think carefully about how we want to handle this in our Estimand to make sure we're able to estimate the right thing and answer the right question. Now, I said earlier that treatment policy is usually the most commonly used strategy. So I think we often default to this. And what this is doing here is this is where we would kind of use the patient's overall survival outcome, regardless of whether they switched or not. So this is really viewing treatment switching as part of the treatment to be evaluated. So what we're getting with a treatment policy strategy is we're really comparing the experimental treatment as a first-line treatment against the experimental treatment as a second-line treatment, even though the experimental treatment would not be available in usual practice. So this comparison isn't really something that's reflective of the effect we'd see in usual practice if the experimental treatment was adopted. Now, if our aims are really to see how effective this experimental treatment would be in usual practice as a first-line treatment, then we need to use a different strategy. We actually need to use the hypothetical strategy here to handle treatment switching, where we're interested in that hypothetical setting where patients who switched from control to intervention hadn't switched treatment, but instead, when they experienced disease progression, were given the second-line standard of care treatment as they would have done in usual practice. So this is an example of what might happen in a fairly standard cancer trial that allowed this type of switching. So if we estimate a treatment policy Estimand, then we're actually going to get a much smaller treatment effect than would actually be the case in real clinical practice. And the reason for this is that if the experimental treatment is effective, then patients in the control arm who switch to the experimental treatment are going to be receiving some benefit that they would not be receiving in usual practice. And so this has the effect of making the treatment effect smaller because it's making the two treatment conditions more similar. And because this treatment effect is smaller, it's actually going to be much harder for us in our trial to find strong statistical evidence of an effect, and we're more likely to get inconclusive results. Now, conversely, if we estimate the hypothetical Estimand, we're getting the much larger treatment effect that's reflective of how useful the experimental treatment would be in part of usual practice. And because we have this much larger treatment effect, it's going to be much easier for us to kind of identify strong evidence of that effect and get a much more conclusive answer to our question. So I think thinking through the Estimand and aligning our study methods to that Estimand can have a real impact in practice. And if we don't do those things, I think there's a real danger that our trial may not be able to successfully meet its objective. So just to wrap up, Estimands are really about clarity, making sure that everyone understands what it is that the trial is estimating, and using that clarity to make sure that what we're estimating is clinically relevant and matches our overall trial objectives, and also to make sure we're able to align our study methods, so the trial design, the data we're collecting, and the statistical analysis to that Estimand to make sure we're able in our trial to estimate the right thing. So thank you very much for your time. I am going to stop there and happy to answer any questions that you have. Thank you.
Thank you, Brennan. That was a really nice and clear introduction to Estimands and why they matter. So we have got a few minutes for questions here. So we've had a couple come in the Q&A panel. So I'll just start with the first that's come in from Bernard North. So he asks, what sort of role do you think Estimands have outside of drug intervention trials? So for example, in screening trials or in surgical trials?
Yeah, that's a really nice question, because obviously I think Estimands, with the addendum, they really were thinking about drug trials, but I think Estimands are really useful for any type of trial. So most of the trials I work on are not drug trials, they're trials of complex interventions. And I personally found Estimands to be really helpful in thinking through kind of how to handle some of those unique intercurrent events we get in trials of complex interventions, and thinking about, what it is that we're actually trying to estimate in these trials and how to kind of align our methods. So I do think estimands are really useful in any type of trial.
Great. So we've got next question here from Susan Tompkins. She asks, in the protocol, we detail the primary endpoint. Will the protocol need to detail the primary estimand used now?
So I will just give my own opinion, but yeah, I think the protocol should include the Estimand, because I think Estimands are really about kind of at the beginning of the trial, thinking through what you're trying to estimate and making sure that you use the right study methods to do that. So I think it's quite useful to include that detail in the protocol.
Excellent. So we have had a question from someone who asked, what methods do you use to estimate the treatment effect in a hypothetical setting? But we will actually be having a talk covering this tomorrow from Ian White. So I know not everyone's coming tomorrow, but I'll you'll get the recordings for that. So that will get answered tomorrow. And we've got another question from Paolo, who asks, is a while not progressed Estimand perhaps another option that you could have used in the advanced cancer trial? So now you looked at the hypothetical and treatment policy. What would your thoughts be on while not progressed in that setting?
Yeah, I think that is an option. I would say it sort of depends on your objectives. So if the objective is really to kind of mimic the effect that we'd see in usual practice, then I think the kind of while not progressed doesn't quite capture that, because I think in usual practice, we do want to know what happens after disease progression, because that is something that's quite important to the patient and to kind of healthcare systems. So I'm not sure that that strategy quite matches what we're interested in, although quite often we do have kind of secondary objectives as well. So it might be something that's worthwhile in that context. So it really depends on the objective, I'd say.
Definitely. And so another question. So someone asks, are we not just making trials more complicated by using Estimands? So what would you say to that, Brennan?
I would say that actually, since I've started using Estimands in my own trial, I found them to be a lot simpler. And because, like I said, Estimands to me are really about clarity, about clarifying kind of what our aims are, so that it's much easier to understand. And I think clarifying what we're trying to do, I don't think makes it more complicated. I think that just actually makes it a lot easier. And for me personally, once we started to use Estimands to clarify, oh, this is actually what we're trying to estimate, that made everything else. So kind of deciding on the right analysis approach, what data to collect, that really simplified that process as well. So I would say actually, this doesn't really make it harder. I think in a lot of ways, it really simplifies the process.
Great, I have to agree with you there. Brilliant. So this might just be the last question. So Francois asks, do you need to adjust for multiple comparisons if you're using different Estimands in an analysis?
That's a really good question. And I don't have an answer for that. I'm not sure there's particularly been any universal guidance on that. Yeah, I don't know that I necessarily would, but I think it probably depends whether you're doing a drug trial where you might need to submit to regulatory authorities versus trial of complex intervention where you don't necessarily need to have the same approach to multiple comparisons. But I think I probably would think about designating a primary Estimand and a secondary Estimand. And so probably not adjusting for multiple comparisons there. But I do think it probably depends on context.
Agree. Brilliant. Well, thank you, Brennan. So we've run out of time for any more questions now. So I'd just like to thank you again for speaking to us. It's a really great start to the day. Excellent. And so that now leads me to introduce our next speaker. So up next, it's my pleasure to introduce Dr. Thinzar Min. So Dr. Thinzar Min is a clinical senior lecturer and a consultant physician in general internal medicine and diabetes and endocrinology. So she's based at the University of Swansea, and she's going to talk to us today about the use of Estimands in diabetes studies. As before, if you've got any questions for Thinzar, do pop these in the Q&A panel. But for now, over to you, Thinzar.
Morning, everyone. I am Tinza. Thank you for introduction and thank you very much for inviting me to join this Estimand workshop, which is very informative. So my background is a clinical researcher. So my talk will be mainly based on clinician perspective, someone who is reading the result of the clinical trial and trying to interpret and what that's mean. So I have nothing to declare regarding to that. But to be honest, I am not a statistician, so I don't really know very detail about statistical method as Brennan or Causey, so bear with me. So I prepare my talk based on the three parts. The background, a little bit background before the Estimand has been implemented and what we've been using in clinical trial at that time. And then what the Estimand, I think Brendan has covered that part, so I can skip most of that. And then I give you one example of the Estimand that employed in the diabetes trial. So in diabetes clinical trial or in any randomized control trial, intention to treat analysis is widely recommended and widely used. So because intention to treat analysis is included all the randomization in the final analysis, regardless of the occurrence or intercurrent events, it mirrors the real-life clinical practice. ITT, it can also prevent the conscious and unconscious attempt to influence the result of the study by excluding the patient. As a result, it is conservative for estimate of the treatment difference, and it might underestimate the treatment effect. Brendan has talked about a lot on the intercurrent events. So we use a randomized control trial to prevent the bias, but intercurrent events that happen post-randomization. And in the trial protocol, most of the trial protocol does not mention how they manage the intercurrent events, especially in also the diabetes trial. We have to try to figure out what to do in the method section or how they're going to deal with that kind of data. So the intercurrent events that in diabetes trial are usually the most common one is the use of rescue medication. Because of the ethical reason, the patients are allowed to use the additional therapy if they're not achieving their target glycemic control within a specified period or time. The second one is a premature discontinuation of trial medication. It could be because of side effect or it could be other events. And another one is loss to follow-up and mortality. But because of some of the intercurrent events, they might lead to the no observed value at the end of trial period, such as loss to follow-up patient. We cannot get any data or any value at the end of the trial, or a patient who die, there will be any observed value at the end of the trial. So how they did it, or what they did for the value in the past. In the past, less observation carry forward method was used to manage some of these missing values. As you all probably know, less observation carry forward method has their limitation and deficiency because it could overestimate the treatment effect because the less observation carry forward, it assumed that the patient who have a very good short-term outcome will continue to have a long-term outcome going forward. But in most of the real cases, it might not be it. Again, it can underestimate the treatment effect of the medication, which appear later course of the treatment or which appear in the later part of the trial. Let me give you one example of that. So dapagliflozin is a relatively newer glucose lowering medication. It was we got the license in 2014, but the sponsor submitted the efficacy data of dapagliflozin to FDA in 2011. The user intention to treat analysis, the primary endpoint was change in HbA1c from the baseline at 24 weeks. Because of the ethical reason, rescue medication or additional add-on therapy, in addition to dapagliflozin, are allowed according to the protocol. But when the sponsor submit the data to the FDA, what they do is that they discuss the HbA1c value after rescue medication. So what they try to establish is that they want to establish the treatment effect of dapagliflozin without having the patient having rescue medication. What they did is that they use the last observation carry forward method. They use the last value that before the rescue medication was used, and then as a carry forward. So when they submit to the FDA reviewer published that report saying that there was more awareness in the statistical community of the limitation or last observation carry forward. His own preferred method is a simply use of the value of the patient who were rescued. So from the sponsor perspective, the sponsor trying to establish the treatment effect of dapagliflozin that no patient received the rescue medication. But from the regulatory perspective, from the FDA perspective, they wanted to establish the treatment policy. If the dapagliflozin is being used in the real setting, dapagliflozin plus rescue medication versus the control plus rescue medication. So as you can see in this example, different stakeholders have different perspectives. That's why Estimand come in. Estimand can give you the different perspective, can answer the different scientific questions, and to cover different stakeholder perspective or view. So, okay. So my second bit is what is Estimand. I think Brennan has been covered, so I'm not going to go in detail about the Estimand. Estimand, to me, what I understand for the Estimand is that it is a detailed description of what needs to be estimated to address the scientific question or interest. It got 5 elements, as Brennan mentioned. So population, behavioral interest, treatment, handling of intercurrent events, and summary measure. Brennan has mentioned strategy, so I will skip this. And let me give you some example of Estimand in the diabetes clinical trial. So let me put the Estimand in the diabetes clinical trial context. So the population for this, it could be the diabetes patient, it could be type 2 patient or type 4 diabetes. Behavioral interest, usually our main aim is to look at the efficacy of diabetes medication. So in terms of changing HbA1c from baseline or changing the plasma glucose, fasting plasma glucose from the baseline. The treatment effect, it could be glucose lowering medication and an investigation. And intercurrent events is the rescue medication, premature discontinuation, loss to follow-up, death. The summary measure could be main difference between the two treatment groups. So this is another example of the diabetes clinical trial. So randomized control trial, let's say that we're going to investigate medication A for the new treatment for type 2 diabetes, control with diet and lifestyle. So the population interest in that case would be, that my understanding would be that the patient with type 2 diabetes control with diet and lifestyle. The treatment description, the main treatment description will be new glucose lowering medication, drug A versus the control medication or placebo. Behavioral interest, primary endpoint, usually our primary endpoint is changing HbA1c from baseline at 26 weeks. And then we can employ different types of estimates, even for one primary endpoint. So depend on, based on how we're going to manage the intercurrent event. So the first one could be hypothetical estimate. It measures effect if all the patients had continued using that drug A without using any rescue medication, any additional diabetes medication such as insulin or any other established diabetes therapy. And the treatment policy that similarly to the intention to treat analysis, it mentions the treatment effect irrespective of trial product discontinuation or use of rescue medication. And then composite estimate sometimes come in handy. It could measure the difference in proportion of patients who achieve a recommended HbA1c target, such as 6.5% at the end of trial without having any rescue medication or who adhere to the trial product. Yeah. So why the estimates are important? Because the different results on the even on the same endpoint, it can create the different results by using different estimates. When I first reading the Pioneer, one of the clinical trials that implying the estimate, I get lost because the results are not the same. Because if you use different estimates, the primary endpoint for each estimate they cannot be the same. So it is very important to us when we read the clinical trial result, what scientific question and what estimate do these results address? To be clear, let me give you one example of the diabetes clinical trial that employing the estimate. So Pioneer is a global phase 3 clinical trial for oral semaglutide. Who doesn't know oral semaglutide? It is a relatively new treatment for type 2 diabetes. It is glucagon-like peptide 1 receptor antagonist. And so in the Pioneer trial program, it included 10 trials. They employ 2 estimates for primary endpoint or the same secondary endpoint. So one is the treatment policy estimate, 2 is the trial product estimate. I'll give you one example from the Pioneer 1. So Pioneer 1 is 26-week randomized control, double-blind, placebo-controlled trial. It is a global study. It across 9 countries. It conducted at 92 sites. The trial objective for Pioneer 1 was to compare the efficacy and safety of oral semaglutide as a monotherapy with placebo in patients with type 2 diabetes. So as I said before, they employ 2 estimates. 2 estimates address 2 efficacy-related endpoints. So the treatment policy estimate is going to measure the treatment effect regardless of trial product discontinuation or rescue medication usage. And then the trial product estimate or hypothetical estimate that will measure the effect of the trial product if the patient can adhere to this trial medication or semaglutide without using any rescue or any additional glucose lowering medication. So this is the result. The primary endpoint for most clinical diabetes clinical trial is the efficacy change in HbA1c. So in Pioneer 1, primary endpoint was change in HbA1c from baseline to week 26. So I did that and also answer the question that whether you can use different estimates for one endpoint. Yeah, you can use a different estimate to answer the different scientific question even for one primary endpoint. So when you look at on the left side is the treatment policy estimate, on the right side is trial product estimate. So in the Pioneer 1, they will be trying to establish the treatment effect or efficacy effect of the 3 different dosage strengths of oral semaglutide. So 3 milligrams, 7 milligrams, and 14 milligrams against placebo. As you can see, on the treatment policy estimate, let's look at the example of 14 milligram of oral semaglutide, the gray one. So the HbA1c reduction from baseline was minus 15 millimole per mole. But when you look at the trial product estimate, the HbA1c reduction was 16 millimole per mole. So they are not the same. that give us the confusion to the reader if you are not familiar to the estimand, especially for I think it's mainly for clinicians. And then when I first read in the before, I'm completely blown away and I have no idea what it is. And then look through what estimand it is, and then got some idea. So yeah, so in the Pioneer one, as you can see, the imply to estimand, and then the treatment, they try to clearly show that what are they going to be the treatment effect or the oral semaglutide, or what are the trial product effect or the oral semaglutide. Okay. So again, so they can also do the secondary endpoint. Secondary endpoint is a change in the body weight from baseline to the week 26. So the same on the left side is a treatment policy estimate. On the right side, a trial product estimate. As you can see, the result for the change in the body weight are not the same between the two estimates. That give the clinician or the reader confusion what to look for. But, okay, so my conclusion is that different estimates address different scientific questions. It is important to look at which question the results are going to address and then answer. When you look at the hypothetical estimate, that hypothetical or trial product estimate, it can tell the clinician, tell us the true effect of glucose lowering effect of that new medication, if the patient is willing and is able to take it as a directive, as a prescribed. But in reality, that is not the case. So in that case, treatment policy estimand is handy, and it can give us the information. It describes how the treatment will work in the real life clinical setting, where the additional rescue medication is common, or where the treatment discontinuation is also a common part of the routine clinical setting. So in that case, from the diabetes clinical trial, that's my landing point for there is that you need to read what type of estimate they describe. And then even though you're going to get the different type of, not the same result for the same primary endpoint, but if there is a significant difference between the result, like for example, the treatment effect is not very good, but the trial product medication, the result for just a hypothetical estimate is very, very good. In that case, it raises some question about the tolerability of this medication in the real life, whether it is really effective or whether there might be some other underlying interference events going on. So, and then the last bit is a composite estimate. It might seek to combine the facets of the intercurrent event, that is, as I said before, it could measure the proportion of the patient to achieve their glycemic target if they are adhere to the trial medication. So I think I'm going to stop here. If you have any question, I'm happy to take, but I'm not quite sure how much detail I can answer, to be honest.
Thank you, Thinzar. That was really nice to hear about an area where estimands are already being used and adding clarity on what's being estimated. I was just really intrigued to ask you, how did you first come to hear about estimands yourself?
Actually, with the Pioneer trial. So when I read it, and then it really cleared my mind, blew my mind. And look at the primary endpoint. I look at okay, but the results are not the same. So what is the difference? And then I come to land the term about the Estimand, and then.
Are many of your clinical colleagues aware of Estimands? Do Estimands come up in many of your clinical conversations?
Not much, to be honest.
No, well, hopefully we can change that. And then we just got a question from Alimu asks, in the Pioneer trial, were both of the Estimands used as the primary endpoint, or was one of them framed as a sensitivity analysis? I don't know if you can recall that. It might.
I think the second one, I'm not quite sure about the sensitivity analysis. I think, as far as my understanding, is that they trying to use to employ the two Estimand. I think based on the experience from dapagliflozin trial. So in the dapagliflozin, as I said, the FDA with different type of Estimand, and then the sponsor what they try to do is they try a product Estimand type of data. So I think that's the way that they employed it. That's my understanding.
Okay. Well, thank you very much, Dinza. I think that takes us up to time for questions. So thank you for joining us. It's been really nice to hear your clinical perspective.
Thank you.